Welcome to Med One Pager. My name is Benjamin, and today I'm going to be talking about prostate cancer. So when we look at prostate cancer, this is the malignant tumor of the prostate gland. And we shall begin by recapping the relevant anatomy in regards to the spread of the cancer. So we looked at benign prostatic hyperplasia, which is an non-cancerous enlargement. And if you haven't watched the video, please do watch it because it has the diagrams or the illustrations of the prostate and some of the anatomy is covered in that video. So in this video, I'm going to focus mainly on the anatomy that is in regards to prostate cancer specifically. So the prostate is located below the bladder, surrounds the urethra, and it is anterior to the rectum. So the zones, we have the peripheral zone, we have the central zone, and we have the transitional zone. In the video of BPH, we said the transitional zone is where and the central zone is where we have the BPH occurring, and the cancer is mostly going to occur in the peripheral zone. So anteriorly, we have the anterior fibromuscular stroma. So the capsule of the prostate gland is going to be incomplete arterially, and this is important because that incompleteness is what is going to make the extracapsular spread easy. And then when we look at the lymphatic drainage, it's going to be drained by the internal iliac nodes, the obturator and the presacral, which all go to the para-aortic lymph nodes and then the supraclavicular lymph nodes. Then when we look at the veins, the prostate is drained by the prostatic venous plexus, which communicates with the Batson plexus, and this communication has no valves, so there can be retrograde flow of blood from the prostatic venous plexus to Batson plexus. And this is important because it explains how we have metastasis to the vertebra. Then we have the fascia of Denonvilliers, and this one is a fascia that is located between the rectum and the prostate gland, and this one is what prevents the spread of the cancer to the rectum. And most of the times you find that people who have actually prostate cancer, the rectum is not ulcerated or infiltrated most of the time. So when you look at the etiology and the pathogenesis of prostate cancer, it is multifactorial process that is going to involve an interplay between hormones, genes, and environment. So when we look at the hormones, we look at the androgens, and it has an androgen dependence where we have a prostate growth and function is going to rely mainly on the androgens, that is testosterone and dihydrotestosterone. So this dihydrotestosterone is going to bind to androgen receptors and activates growth as well as survival genes. So when this happens, we shall have proliferation. That is sometimes normal, but when things go wrong, we have cancer cells coming in, and when cancer cells come in, they tend to retain that androgen sensitivity earlier on. So during the early ages of the cancer is going to be driven by the androgens, and that is why when we do androgen deprivation therapy, it's going to work. But that is initially. Then what is going to happen is that we have genetic alterations that are going to open. For example, if you have the TMPRSS2 egg fusion, which is going to promote oncogenic transcription. If we have loss of P10 and gain of P3 and RB1, we shall have progression to aggressive forms, and we shall have what we call the androgen-independent forms, or the castration-resistant form of prostate cancer. Then if we have the BRCA1, if you have the BRCA2 mutation, which is also associated with breast cancer, the BRCA2 or the ATM mutation will predispose to early onset high-grade disease. So just a quick recap about the BRCA1 and BRCA2. The BRCA1 is the most common cause of breast cancer in men, but the BRCA2 is associated more with prostate cancer. So when you look at other environmental factors and other things like inflammation and oxidative stress, whenever you have a chronic prostatitis or we are having infections, it's going to be release of reactive oxygen species which cause DNA damage. When DNA is damaged, we have neoplastic transformation. Then the progression, it's going to start as prostatic intraepithelial neoplasia, which is localized. Then we have the localized adenocarcinoma. That means you have breached the basement membrane. Wherever we have an intraepithelial neoplasia, it means we have not yet exceeded the basement membrane. Then we have the extraprostatic extensions and metastasis when we leave the capsule of the prostate. So the clinical features of a disease, usually it is asymptomatic and it may be detected via PSA or rectal screening. But it may cause the lower urinary tract symptoms, that is the FAN, frequency, urgency, nocturia, or weak stream, and it is similar to BPH in this case. And occasionally we may have hematuria or hemospermia, that is blood in the urine, hematuria, and hemospermia is blood in the sperm in the ejaculate. Then sometimes we have what we call a histological surprise, whereby a resection is done for BPH, but when we do histology, you find that actually the patient also had a cancer. And in this case, some of these cases, you may have to ask yourself what to do next. Are you going for radiotherapy? Are you going to do watchful waiting? It's going to be depending on that. It's also important to mention earlier that BPH is not a risk factor for development of prostate cancer. And much as the hyperplasia does not transfer, it is also possible to have a coexistence where we have the hyperplasia as well as the carcinoma. So when you consider the clinical features, sometimes we can have the locally advanced disease where we have involvement of the perineal, pelvic, or lower back pain. So when we have perineal pain, pelvic pain, or lower back pain, we can have urinary retention, and then we can have rectal involvement where we have a fixed prostate. That is on the rectal examination. When you try to feel for the movement of the rectal mucosa, it's actually fixed, and we have a rectal wall thickening. Then we can sometimes have clinical features where a patient presents with metastatic disease and they'll present with bone pain, and sometimes this is going to be considered probably rheumatism. Sometimes someone has bilateral sciatica, so you find an elderly man with bilateral sciatica, and most times it's going to be due to this PPH. Then we can have pathological fractures. We can have spinal cord compressions, and we develop things like the leg weakness, the sensory loss, urinary and fecal incontinence. Then we have constitutional symptoms of cancer like weight loss, fatigue, and anemia. So when you look at the screening on the early detection, so screening is going to aim at detecting the disease early before symptoms appear, but the problem is it carries a high risk of poor diagnosis. So whenever we are approaching a patient with a suspicion of prostate cancer or within the risk or who has risk of developing prostate cancer, we're going to do the following. One, we have PSA, which is a prostate-specific antigen. So the prostate-specific antigen is produced by the prostate gland, and it is thought to have a role in liquefying of semen. So what happens is that normally we have less than 4 nanograms per ml of prostate-specific antigen in our blood. But then as age comes about, as we have this growth of the prostate gland, we are going to have an increase in the amount of prostate. So there are age-specific cutoffs that have been put. For example, someone who is below, for someone who is less than 50 years should have at least less than 2.5, less than 3.5 for 40 to 60 years, and greater than 60 years, we expect to have less than 4.5. But generally, less than 4.5, if someone has greater than 4.5, we can suspect maybe they have something wrong going on. Greater than 10 is suggestive of a cancer. And when we have a greater than 35 nanograms per ml, that is a sign of disseminated cancer. But interpretation, so we came up with these interpretation nuances to explain, because not everyone that has a high PSA is going to have a cancer. And things have to be considered, like the size, the age, and other things that come in. So we came up with 3 more parameters about the PSA that will help us really increase or they add nuance to understanding whether this is really carcinoma or this is benign. So what we do is we do a PSA density, whereby the PSA is divided by the prostate volume. And then if we have a PSA density greater than 0.15 or 0.15, we shall say we are suspicious of having a malignancy. Then we look at the PSA velocity, which is the rate of rise of the PSA. If we have a rate of rise greater than 0.75 nanograms per mil per year, then still we shall have a suspicion that we have prostate cancer occurring here. Then we shall do the dictorectal examination on top of that. And the dictorectal examination, we shall feel a hard, nodular, irregular fixation, posterior surface, and this is only going to detect posterior lesion. And that is why we don't do a dictorectal only. So we combine it with the PSA to increase on the sensitivity. So who are we going to screen? We are going to, an average risk starts at 50 years, and we shall screen high risk people, that is people from African descent, family history, and for those ones we shall start at 40 to 45 years. In the screening interval is going to be 1 to 2 years with a shared decision making between the practitioner and the patient. Then we have the diagnosis. So the diagnosis of prostate cancer is generally going to be a histological diagnosis, and PSA findings and dictorectal examination findings are always going to be a baseline, or they're going to come first and they will determine the need for imaging and biopsy. So if we do the PSA and the DRE and we have suspicion of malignancy, then we shall proceed to doing the imaging and then also doing the biopsy. So when we do the imaging, we can do the multiparametric MRI, which combines the two diffusion and dynamic contrast images. Then we can do the PRADS, which is the prostate imaging radiology assessment score, that is going to tell us if we have a score of greater than 3, we are going to be suspicious of the malignancy. And the PRADS is going to resemble the BRADS for the breast cancer breast cancer imaging radiology reporting system. So after that, we may need to do the biopsy, where we shall do a transrectal ultrasound guided systemic biopsy, and we shall pick a minimum of at least 12 cores. And these 12 cores are picked from different areas of the prostate, different zones of the prostate, and each of those is going to be named. And then we shall do the histology, and then we shall report using the Gleason scale, or we shall grade the cancer according to the Gleason grading, which I will explain. Then we have the MRI targeted fusion biopsy, where we do a biopsy basically under MRI, and this is going to improve the accuracy. Then we do the histopathology to confirm adenocarcinoma, and we assign the Gleason or the ISUP grade group. Then we do the staging and workup. Then we can do CT and MRI to see if we have for extra prostatic extensions. If we have lymph nodes, we can do bone scans to detect bone metastasis. Then we can do the PET-CT, which is sensitive for nodal and distant spread. So when you look at the Gleason scoring, it's going to grade prostate adenocarcinoma based on granule architecture. So it uses the principle whereby most times when we have carcinoma of the prostate, we have different histological patterns. And these histological patterns, we choose the two most common histological patterns, which we shall consider one, the primary, which is the most common pattern, and then the secondary, which is the second most common pattern. So we shall report it as for example, as the primary plus the secondary, and then we get a total. And the total is going to range from 2 to 10. So the patterns we have 1 to 2, which is well differentiated, and then 3, which are infiltrative small glands, then 4, where we have fused cribriform glands, and 5, where we have solid sheets or necrosis. So this is basically just showing us how differentiation is worsening as we go down. So when reach the grading, if the most predominant pattern, for example, if the most predominant pattern here in a given patient is infiltrative small glands, then the primary or the reporting will be 3. Then if it is the second most common is 4, then we shall put 3 plus 4, and 3 plus 4 is 7. And then we shall look for the ISP grade. So the ISP grade 1 is when we have less than 6. Grade 2 is when we have 3 plus 4. Grade 3 is when we have 4 plus 3. So you can see that 4 plus 3 is worse than 3 plus 4. And this is because 4 plus 3, the 4 is the primary or the most common. The 4 is going to start for the primary or the most common lesion. So when you look at the most common histological pattern in grade 3, it's going to be 4. That is because that means we have mostly fused or cribriform glands, and then we have infiltrative small glands later. But when you look at 3 plus 4, the most common histological pattern is the infiltrative glands. So this one has a better prognosis. 3 plus 4 has a better prognosis than 4 plus 3. Then we have 4, which we have 8, and then 5, which we have 9 to 10, the score. So when we do the biopsy, we take 10 to 12 true scores and we grade them separately. And then the one that has the highest grade is the one that is going to have the highest, is the one that we are going to consider. Then we have the minor grade, whereby if we have someone with a higher grade that is possible, we call that a tertiary pattern. So for example, if someone has a 3 plus 4, yes. But again, they have a 5 somewhere. We cannot ignore the 5. So the 5 will be the tertiary pattern. It is always going to worsen the prognosis. So how we are going to interpret this? If we have a Gleason score of less than 6, that is a low risk. 7 is intermediate, and 8 to 10 is high. And it is used with the PSA and the TNM for the management decisions. And I'm going to explain the TNM staging of cancer next. So for prostate cancer, when we are grading it, the TNM, we're going to have T1, T2, T3, and T4. So T1 is when you have a non-palpable, or when we see just the prostate cancer incidentally. Then T2 is when we have palpable, but it's confined to the prostate, and most times you can even still feel the median sulcus. Then whenever we reach T3, T3 is when we leave the capsule. So beyond T3, we have now extraprostatic invasion. And then T4 is when we invade adjacent organs such as the bladder, the rectum. Then lymph nodes, we have N1 and N0. So N0, no lymph nodes. N1, we have regional lymph nodes or regional node metastasis. Then M0, no metastasis. M1 is when we have the metastasis. So when we go to the complications of prostate cancer, most of the time we have disease, we have bone metastasis, we have fractures, we have cord compression, we have obstruction, we have anemia and cachexia. And the treatment of this prostate cancer is also going to come with its own complications. That's going to include surgery, where we can have incontinence and erectile dysfunction. When we do the androgen deterioration therapy, we can have things like hot flashes, gynecomastia, osteoporosis, metabolic syndrome. Then when we do the radiation therapy, we can have things like cystitis, proctitis, and infertility. And we're going to look at those different management protocols down shortly. So the prognosis is going to depend on the stage, the PSA, and the Gleason. So the histological grade of that cancer is going to determine a lot when it comes to the what? When it comes to the survival of this patient. And the 5-year survival, for localized is greater than 98%. So you can say that the 5-year survival rate in these patients is quite good, and it's actually a slow growing cancer in most of the cases. In the regional, if you have regional spread, it is 85 to 90%. And when we have a poor Gleason, that is a Gleason score greater than 8, a PSA greater than 20, and Mets, we are having a very poor, we're going to have a poor prognosis. Then the prevention, we want to decrease red meat, dairy, want to increase fruits like tomatoes, which have lycopene, want to use the omega-3s, exercise, weight loss, weight control, stop smoking. Then some drugs like finasteride and dutasteride, these ones are anti-androgen drugs, are going to decrease the incidence of prostate cancer, but also in some cases they're going to increase the grade. high grade risk because you may not actually experience the symptoms of the cancer earlier on, and then by the time you actually get to realize that things have gone out of hand or you have the cancer is when it's too late and you have an advanced grade. So management, when it is localized, we can do active surveillance in low risk individuals or people who have a limited life expectancy. Someone has less than 5 years of life, then we may not consider going or being so radical with them. Then we have radical prostatectomy, that is for fit, and when we have localized individuals. And the complication of this is that we can have impotence and incontinence coming in. Then we can consider radiotherapy, that is external beam radiation therapy and brachytherapy. And these ones come with side effects of cystitis, proctitis, and impotence. Then if it is locally advanced, most of the times we can consider doing an external beam radiation therapy plus androgen deprivation therapy for 2 to 3 years. Then metastatic disease, we want to do androgen deprivation therapy, and that can include doing a bilateral chudectomy plus an LHRH leukotriene hormone releasing hormone agonist, luteinizing hormone releasing hormone agonist, and this one is going to increase the release of luteinizing hormone. So luteinizing hormone most of the time is produced in a pulsatile manner. So when you give an agonist and the pulsatility dies, we're going to have issues with the production of a luteinizing hormone, which actually acts on the testicles to increase production of testosterone. So that way we are stopping. Then the antagonist is going to actually now just antagonize the production of luteinizing hormone. The problem with the agonist is that we have a flare-up. So when you first start giving therapy, there can be that flare-up or an increase in luteinizing hormone, which will again worsen the disease for a while before it actually begins to go down. So you should be careful when you are considering using a luteinizing hormone receptor, a luteinizing hormone releasing hormone agonist. Then we have the CRPC, where we can use abiraterone, xalutamide, and doxazoxil. Then palliatively, we can give drugs like bisphosphonates, external beam radiation therapy for pain, spinal decompression. We can do analgesia, transurethral resection of the prostate, or catheterization if we have obstruction. And this can include use of a suprapubic catheter. So we've come to the end of our discussion about prostate cancer. I hope this makes sense, and I hope a lot of these different concepts when it comes to prostate cancer can or have been explained very well. So if you did not understand anything, or if you want me to explain anything, please write it down in the comment section. Don't forget to leave a comment. Don't forget to leave a like and share this video with a friend. My name is Benjamin. Have a nice time.